طيب، بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله. Welcome everybody. It's my pleasure to be with you today to have the second day of our symposium or course about thyroid disorders. The first day was presented by my colleague, Dr. Hamid, and I hope it was interesting for all of you. And the journey is continued today. We have some topics to be covered as well. We know thyroid diseases are common, especially in women, and we have varieties of thyroid disorders, including hyperfunctioning or hypofunctioning, for example, related to fertility issue, pregnancy, etc. So I hope that it will be beneficial for all of you. Let's start our first topic today without any further delay. So this is just ice breaking to pay your attention. Let's talk about hyperthyroidism. I will try to focus on toxic nodular goiter, definition, epidemiology, causes, clinical presentation, laboratory diagnosis, and management. What about the definition? We know hyperthyroidism is hypermetabolic status resulting from excess thyroid hormone, and epidemiology, as you see here, the iodine deficiency. It depends on the position of the country beside sea or away from the sea. We see some countries has an optimal iodine supply or status, but we have some other countries with severe, moderate, or mild iodine deficiency. Hyperthyroidism is more common in female than in male. 5:1 is the ratio. The overall prevalence of hyperthyroidism, which is approximately 1.3%, increased to 4 to 5% in older female. Hyperthyroidism is also more common in smoker. Graves' disease is seen most often in younger female, while toxic nodular goiter more common in elderly population. Several causes, including, as you see here, several different disorders can cause hyperthyroidism. It is essential that the correct cause be identified because appropriate therapy depends upon the underlying mechanism of hyperthyroidism. From a pathogenic viewpoint, hyperthyroidism results from two different mechanisms which can be distinguished by finding of 24-hour radioiodine uptake. Causes, number one, category called hyperthyroidism with normal or high radioiodine uptake. Autoimmune thyroid disease and autonomous thyroid tissue are the major causes of excess new hormone synthesis by thyroid gland. Hyperthyroidism with normal or high radioiodine uptake indicate de novo synthesis of hormone from the gland itself. These disorders can be treated with thionamide, such as carbimazole or methimazole, which will interfere with hormone synthesis. Hyperthyroidism with normal or high radioiodine uptake. Number one differential is autoimmune thyroid disease, and we have two categories here or two items. Number one is Graves' disease, which was elaborated yesterday by Dr. Hamid, and the second one, Hashimoto's psychosis. The second category is autoimmune thyroid disorder. And we have toxic adenoma, toxic multinodular goiter items, and TSH-mediated hyperthyroidism, which include TSH-producing pituitary adenoma, non-neoplastic TSH-mediated hyperthyroidism. And the fourth one, human chorionic gonadotropin-mediated. And we have two items, hyperemesis gravidarum and trophoblastic disease. Hyperthyroidism with a near absent radioiodine uptake. This is the second category. And what we have here, hyperthyroidism with absent radio uptake. If you go for nuclear medicine or nuclear study, we have zero uptake or low uptake, either indicate inflammation and destruction of thyroid tissue with the release of performed hormone into circulation, or an extrathyroidal source of thyroid hormone. Thyroid hormone is not being actively synthesized when hyperthyroidism is due to thyroid inflammation. As a result, thionamide therapy is not useful in this disorder. What are the differential diagnoses here? Number one, thyroiditis, and include subacute granulomatous thyroiditis. It is called Decoivan. Second example, painless thyroiditis, also known as silent or lymphocytic thyroiditis. Number three, postpartum thyroiditis. Number four, amiodarone, also cause iodine-induced hyperthyroidism, radiation thyroiditis, and palpation thyroiditis. All of these are examples. Second category called exogenous thyroid hormone intake, and the differential diagnosis here include excessive replacement therapy, intentional suppressive therapy, factitious hyperthyroidism. And we mean by factitious hyperthyroidism, if somebody using levothyroxine, for example, from outside, either from healthcare provider who has or who have an easy access to medication, or some patients may be using levothyroxine to lose their weight, and again maybe it is available in some herbal medications or herbal drugs. So this is also under the category or item of factitious hyperthyroidism. Finally, we have ectopic hyperthyroidism, two differential diagnoses including stroma ovari, metastatic follicular thyroid cancer. This is the uptake scan, and please keep in your mind that the uptake scan is a cornerstone diagnostic tool, and maybe it is the first diagnostic tool as a radiological investigation. So please, it is a cornerstone to be ordered. So this is the normal uptake scan, and this is the Graves' disease uptake scan. We have an overall scan increased all over the gland, and then we have toxic multinodular goiter. We have nodules in both sides, right and left, all over the gland, and there is hyperfunctioning nodules detected by the scan. And finally, we have one adenoma, which is hyperfunctioning under terminology of toxic adenoma. So either one toxic adenoma or toxic multinodular goiter or Graves' disease, it will help us in the thyroid scan, definitely. Again, if patient has low uptake, for example, you have to think about other differential like thyroiditis. The clinical manifestation of hyperthyroidism are largely independent of its cause. However, the disorder that causes hyperthyroidism may have other effects. In particular, Graves' disease, the most common cause of hypothyroidism, causes unique problems that are not related to high serum thyroid hormone concentration. These include Graves' ophthalmopathy, and infiltrative dermopathy, localized or peritibial myxedema. Most patients with Graves' hyperthyroidism have a diffuse goiter, but so do patients with other less common causes of hyperthyroidism, such as Pallia's thyroiditis and TSH secreting pituitary adenoma. Maybe sometimes you are seeing some effect in the cardiovascular level, increasing pulse rate or tachycardia. This is common. Pulse pressure is wide as well. Peripheral vascular resistance is decreased. Systolic hypertension may be observed. Left ventricular ejection fraction does not increase appropriately during exercise, suggesting the presence of a true cardiomyopathy. High or normal output congestive heart failure can occur in patients with severe hyperthyroidism, and congestive heart failure worsen in patients who already have it. Atrial fibrillation occurs in 10 to 10% of patients with hyperthyroidism and is more common in elderly patients. Maybe in one of the studies, 8% of all patients and 15% of patients between age 70 to 79 developed atrial fibrillation within 30 days of diagnosis of hyperthyroidism. Even subclinical hyperthyroidism is associated with increased rate of atrial ectopy and threefold increase risk of atrial fibrillation. In 60% of hyperthyroid patients with atrial fibrillation, the rhythm converts spontaneously to sinus rhythm when the hyperthyroidism is treated. In one study, all who spontaneously converted did so with 4 months after becoming euthyroid. Among those who do not convert spontaneously to sinus rhythm and who undergoes a successful electrical cardioversion, the two risk of recurrent atrial fibrillation was 59% compared with 83% of patients whose atrial fibrillation was not associated with hyperthyroidism. The role of anticoagulant is controversial in hyperthyroid patients with atrial fibrillation. In severe studies or several studies, 10 to 40% of patients with hyperthyroidism and atrial fibrillation had an atrial embolus. So one of the indications to use anticoagulant in endocrinology is to go for anticoagulate patients who have atrial fibrillation with hyperthyroidism. Left atrial enlargement, which is a risk factor for thrombus formation, is present in about 90% of hyperthyroid patients with atrial fibrillation. Based on these results, we usually anticoagulate hyperthyroid, as we mentioned, using anticoagulant therapy. Other abnormalities, including mitral valve prolapse, regurgitation, and increase in left ventricular mass. Some lipid disorder also observed, including low serum total and high density lipoprotein HDL and low total cholesterol HDL cholesterol ratio. These values increase after treatment. Hyperglycemia, although thyroxine is not a counter-regulatory hormone, hyperthyroidism can interfere with glucose metabolism. It is associated with both increased sensitivity of pancreatic beta cell to glucose, resulting in increased insulin secretion and antagonism to peripheral action of insulin. The latter effect usually predominate, leading to impaired glucose tolerance. Hyperglycemia, one of the observed we can say manifestation in these cases. What about adrenal function? If the patient related to autoimmune disease with hyperthyroidism, maybe there is association with adrenal function. And respiratory, usually we have dyspnea and dyspnea on exertion, oxygen consumption and CO2 production increase These changes result in hypoxemia and hypercapnia as well. Respiratory muscle weakness is an important cause of dyspnea, and reduced exercise capacity may be largely due to respiratory muscle weakness and decreased lung volume. Hyperthyroidism may exacerbate underlying asthma. Pulmonary arterial systolic pressure is increased. Gastrointestinal manifestation include weight loss due to primarily increased metabolic rate, hypermetabolism, and secondarily to increased gut motility and associated with hyperdefecation and malabsorption. Rare patients have steatorrhea as well. Celiac disease is also more prevalent in patients with Graves' disease. Most patients have hyperphagia, but an occasional patient with mild hyperthyroidism may have sufficient appetite stimulation that weight is gained more commonly in younger patients. Anorexia may be predominant in the older people as well. Other changes that may occur include vomiting, abdominal pain, dysphagia due to goiter, abnormalities in liver function test, particularly high serum alkaline phosphatase concentration, and rarely cholestasis. Hematological manifestation, red blood cell mass is increased in hyperthyroidism, but the plasma volume is increased more, resulting in normochromic normocytic anemia. Serum ferritin concentration may be high. Hyperthyroidism maybe also has prothrombotic effect. Genitourinary manifestation include urinary frequency, nocturia are common in hyperthyroidism. Possible causes include primary polydipsia and hypercalcemia, enuresis. In female, sex hormone binding globulin HBG concentration high, which result in high serum estradiol concentration and low normal serum free estradiol concentration. High LH concentration, reduced mid-cycle surge in LH secretion, oligomenorrhea, and ovulatory infertility. Amenorrhea can occur in severe hyperthyroidism as well. In men, the increase in serum SHBG concentration result in high serum total testosterone concentration, but serum-free unbound testosterone concentration are normal or low. Serum LH concentration may be slightly high. Extragonadal conversion of testosterone to estradiol is increased so that serum estradiol concentration are high. Spermatogenesis may be decreased or abnormal. What about the bone? Thyroid hormone stimulate bone resorption, resulting in increased porosity of cortical bone or loss of the cortical bone and reduced volume of trabecular bone. The loss of cortical bone density is greater than that of trabecular bone. We are observing high serum alkaline phosphatase can be seen. Metabolic clearance rate of calcitriol is increased as well. What about neuropsychiatric manifestation? Patient may have psychosis, agitation, or sometimes depression. So irritability and emotional lability, anxiety usually observed. Insomnia also common to be seen in these patients. What about geriatric hyperthyroidism? Hyperthyroidism in elderly, little bit maybe different. Patient will be presented sometimes with apathic condition. He will be quiet rather than having hyperactivity tremor and other symptoms of sympathetic overactivity. 2/3 of such patients have symptoms similar to those in younger patients. In cross-sectional studies of patients with hyperthyroidism, older patients had reduced risk for presence of several classical symptoms, but a higher prevalence of weight loss and shortness of breath compared with younger patients. Also, elderly may have increased rate of atrial fibrillation. What should we do if you suspect hyperthyroid in general? You have, first of all, ask for TSH concentration. It is the first test to be measured. If subnormal, serum free T4 and T3 concentration are run by most laboratories. After that, if serum TSH is low, free T4 and T3 are high, diagnosis of hyperthyroidism is confirmed, and 24-hour thyroid radioiodine uptake should be done as we mentioned. T4 and T3 are high, but TSH is normal or high. Pituitary MRI should be done. Maybe there is suspicion of TSH secreting adenoma. So the hyperthyroidism in this case is not from the thyroid itself, it's actually from pituitary gland. If TSH is low, serum T3 but not free T4 concentration is high, maybe the patient most likely has Graves or autonomous function thyroid adenoma. Possibility of exogenous T3 ingestion should also be considered. The pattern of low TSH, high serum free T4, and normal T3 concentration suggests hyperthyroidism with concurrent non-thyroidal illness, amiodarone therapy, or exogenous T4 ingestion. Patient without overt signs of hyperthyroidism in the setting of low serum TSH and normal free T4, T3 concentration most likely have subclinical hyperthyroidism, and we will try to discuss it today, inshallah. I think how to differentiate between different differential diagnoses of hyperthyroidism. I will concentrate on toxic adenoma and multinodular goiter, TSH will be low, if T4, if T3 will be normal or high. Toxic adenoma and toxic multinodular goiter, as we mentioned before, here we have usually enlarged thyroid, activating somatic mutation in the genes for TSH receptor have been identified in both toxic adenoma and nodules of toxic multinodular goiter. Similarly, activation mutation of GS-alpha protein have been identified in toxic adenoma, but it is uncertain whether they occur in toxic multinodular goiter. Toxic multinodular goiter and toxic adenoma frequently result from somatic mutation in GS-alpha subunit or TSH receptor causing constitutive activation in one or more nodules, which lead to autonomous function of secondary hepatotoxicosis. This is the mechanism of toxic nodular goiter or toxic multinodular goiter. And physical examination usually we find large goiter. Patient can be asymptomatic or exhibit classic symptoms of thyrotoxicosis. Obstructive symptoms due to large goiter may be observed sometime, or sometimes, if there is effect on esophagus or in the respiratory tract, we have these symptoms. With toxic adenoma, thyroid scan will reveal a solitary overactive hot nodule with suppression of non-autonomous extranodular tissue. In contrast, with toxic multinodular goiter, a thyroid scan will reveal patchy uptake of radioactive iodine with increased uptake in autonomous region and reduced uptake outside those areas. In areas of decreased uptake, determining if reduced uptake correlate with normal appearing tissue or a distinct thyroid nodule is essential, because the latter requires specific evaluation, and maybe finding the aspiration sometimes is the proper action for these cold nodules, because there is risk of malignancy. Ultrasonographic finding usually is useful in assessing toxic multinodular goiter, because scan finding can be correlated with normal thyroid architecture, and functional nodules can be delineated from non-functional one. Iodinated contrast should be avoided in patients toxic thyroid nodule if possible, and close monitoring by thyroid function test is indicated. Anti-thyroid drugs also can be used in toxic nodular goiter or toxic multinodular goiter, but usually after 2 years, the definitive treatment is usually radioactive iodine ablation, or the definitive treatment, other definitive treatment that can be used is the surgery. As hyperthyroidism tissue is destroyed over the subsequent few months, the residual tissue after a radioactive iodine ablation, patient will have a hypothyroidism, and definitive replacement with levothyroxine is the best option in this situation. Surgical options, as we mentioned before, including removal of involved lobe in toxic adenoma and total thyroidectomy in toxic multinodular goiter. Patients who undergo total thyroidectomy will require lifelong levothyroxine therapy, but those who have only involved lobe resection may have enough residual thyroid function to work and to release thyroxine hormones. So assessment with thyroid function and monitoring is very essential. Mutation of TSH receptor gene are most common. In one study, they were found in 15 of 31 toxic adenoma. Mutation also usually seen in transmembrane domain of the receptor, but can be in the extracellular domain. Toxic multinodular goiter tend to be more common in area where iodine intake is relatively low. And I am done with this topic. I hope it was clear for all of you. Let's go for the second one. Okay, now the topic to be discussed here is thionamide or anti-thyroid medication. What is the what are the available drugs, and what are the usual side effects of these medication? Thionamides include methimazole, carbimazole, BTU or propylthiouracil, usually effective treatment in patients with Graves' disease. And as I mentioned before, they are used also in patients with toxic adenoma and a patient with toxic multinodular goiter, but maybe it is not the best option in this situation. The clinical use generally of thionamide often started in patients with Graves, as we mentioned before, and a toxic nodular goiter. But again, after 2 years, maybe it's the time to maybe to wean off the medication if the thyroid function will allows you. But if the thyroid function not allowing you, I mean, if it is not normalized, to have continuous use of carbimazole is your option. And again, looking for other definitive treatment like radioactive iodine ablation and surgery is the best option. What are the contraindications? The contraindication include the thionamide. Drugs are contraindicated in patients with previous major adverse reaction like agranulocytosis, hepatotoxicity, and pancreatitis. So please, if you would like to start any of these, keep in your mind that you have to ask about any past history of these disorders. Because they are teratogenic, their use in women desiring pregnancy in the next year or two or two requires careful discussion, because maybe delaying the pregnancy one of the options, but again, incidental pregnancy can occur, and this is what we are seeing in the clinical practice. So using some of the medication in the first trimester, different from other medication in the second and third trimester, is your way to handle this patient. And we'll mention it in today also, inshallah. As we mentioned before, a choice of the therapy, PTU or propylthiouracil and methimazole are the thionamide drugs available in the USA. Carbimazole available in our country here in Saudi Arabia, more common than methimazole. The more potent one is methimazole if you compare it with the carbimazole. Methimazole achieve euthyroid status more rapidly than PTU, especially in patients with more severe hyperthyroidism. It is once daily dosing, can be given, or it can be separated also. Methimazole is less likely than PTU to be associated with failure of radioiodine therapy when thionamide are given to normalize thyroid function before radioiodine treatment. It is less toxic. There have been concern about PTU-associated hepatotoxicity. Again, hepatotoxicity is one of the major side effects related to PTU. That's why it is not the first option. The first option to go with methimazole or carbimazole. Although hepatotoxicity is still a rare complication, the ATA and FDA recommend that PTU not be prescribed as first-line drug in children or adults. However, there are three clinical settings in which PTU is preferred. The first one, as I told you, first trimester of pregnancy. If you compare it with the carbimazole, it is the best to be given here for initial management of patients with life-threatening thyroid toxicosis or thyroid storm, in patients with minor reaction to methimazole who do not want to have definitive treatment with radioiodine or surgery. Rectal and intravenous preparation of methimazole and PTU can be prepared by hospital or compounding pharmacies for selected patients who are temporarily unable to take oral medication. Pre-treatment evaluation, as we mentioned before, pre-treatment evaluation, including prior to initiating thionamide. Please, as we mentioned, do CBC and liver profile. A patient with baseline absolute neutrophilic count less than 1,000 or liver transaminase above 5 times should not initiate or use thionamide. The initial dose of methimazole varies according to the severity of hyperthyroidism. So, for example, free T4, 1 to 1.5 times the upper limit of normal. In patients with small goiter and mild hyperthyroidism, usually treatment start with 5 to 10 milligrams of methimazole once daily. Patient with free T4, 1.5 to 2 times the upper limit of normal. In patient with moderate hyperthyroidism, start usually a dose of 10 to 20 milligrams of methimazole once daily, and 3 times above the upper limit of normal. Patient with large goiter and more severe hyperthyroidism should be started on 20 to 40 milligrams daily. Carbimazole dose required to yield an equivalent dose of methimazole is approximately 40% higher. For example, 10 to 20 milligram dose of carbimazole yield roughly 6 and 15 milligram of methimazole respectively. Our dose recommendations are influenced by dose dependence of the major side effect of methimazole. Usually, there was an old-fashioned to use both methimazole and levothyroxine. It is called blocking and replacing therapy regimen, but nowadays it is not anymore recommended. The doses recommendation are supported by many trials, and usually, as we mentioned before, you have to go for follow-up of T4 and T3 6 weeks after you start the 4 to 6 weeks after you start the medication, and going with titration of your dose up and down is the best way in this situation. Complication of thionamide therapy include rare but serious adverse effects such as agranulocytosis, hepatotoxicity, and pancreatitis are discussed later on. We'll just try to focus on them, but it is the preferred that information about serious adverse event to be given to the patient. What about the monitoring? Patient with toxic nodular goiter, Graves' disease, as we mentioned, we have to go for physical examination every time. If the patient develops jaundice, maybe this is the time to look for a liver function test. If the patient has fever, definitely patient has to go for CBC, maybe leukopenia is resulted after use of thionamide. Duration of the therapy, as we mentioned before, if you start the medication, 2 years use of the antithyroid medication is your option. After that, if the thyroid function allows or normalize, maybe you can try to wean off the medication with monitoring thyroid function. But if it is failed, you have the option to go for radioactive iodine ablation, surgery, or continue on life suppression therapy. One more issue, if the patient has relapse, keep in your mind that second relapse will occur in majority of cases. So if you wean off the medication after use of 2 years and there is relapse, the chance to have another relapse is very high. Sometimes before we go for radioactive iodine ablation or surgery, you have to control the thyroid function test, and again, this is the role of methimazole or carbimazole appears in these cases. As I mentioned before, how to monitor the recurrence, the frequency of prolonged remission among patients treated with thionamide for 1 to 2 years is usually under 40%. Thus, after discontinuation of thionamide, patients require monitoring of recurrent hyperthyroidism. For patients with normal antibodies, which is for Graves' disease and TSH at 12 to 18 months, thionamide are discontinued, and serum TSH free T4, total T3 are usually measured 2 to 3 months after you discontinue the medication, and more frequent, and after that maybe less frequent every 6 to 12 months. Time course of relapse, recurrent hyperthyroidism is initially manifested by low serum TSH concentration. The time to relapse is related to the presence or absence of antibodies. In antibody-positive patient, relapse can occur as soon as 10 days after drug cessation, while in antibody-negative patients, it can take many months or even years for recurrence to develop in that fraction of patients who eventually recur. Prolonged remission is likely if the patient remains euthyroid for 6 months. So again, if the patients continue to have a normal thyroid function for 6 months, prolonged remission is usually seen, and late relapse occur in about 10% as well. The treatment of recurrence, again, using methimazole definitive treatment with radioactive iodine surgery is your option in these cases. Predictor of remission. How we can predict? Because remission rate among patients treated with thioramide are variable, establishing criteria to predict the likelihood of remission when the patient is first seen would be helpful in the discussion of treatment option with patient. And the clinical factors, including remission rate, were higher in female than in patient with mild hyperthyroidism, small goiter, or a goiter that reduced in size during thioramide therapy compared with large goiter. Age over 40 years, cessation of cigarette smoking also increased the chance of remission. Remission rate were lower in patients with severe ophthalmopathy, men compared with women, 20 versus 40% patient under age of 40 years compared with older population. What is the role of duration of therapy? Longer duration of therapy improve remission rate. This is the usual in any autoimmune disease, which have been reported to be high as 84% after 5 to 10 years of treatment. In children, remission rate increased from 25% in those treated for 2 years to 75% in those treated for 11 years. Similar conclusions were drawn in subsequent prospective study in children. I have a brief video about anti-thyroid drugs. Please concentrate.
Hi everyone. Today in this video, let us discuss about the anti-thyroid agents. Hyperthyroidism is one of the conditions where there is an excessive release of the thyroid hormones like the T3 and T4, and sometimes this disorder may also result because of the autoimmune disorder. For example, the Graves' disease, excessive thyroid hormones are going to be released, which results in the hyperthyroidism. Particularly in the hyperthyroidism, the basic metabolic rate is going to be increased because of the increased levels of the thyroid hormones, which may result in the variable effects on our physiological system. Generally, fatigue is observed in the patients, and because of the increased levels of the thyroid hormones, irritability and nervousness is observed in the patients. And it also affects the heart to produce irregular heartbeat. So palpitations can be observed, which may be irregular. And insomnia, lack of sleep, is another important disorder that can be observed with the hyperthyroidism. And apart from these symptoms, it can also produce tremor in the patients, diarrhea. It can alter the movement of the bowel, which results in the diarrhea, and protrusion of the eyeballs. Particularly, Graves' disease is associated with the protrusion of eyeballs, so that's why it is called as exophthalmic hyperthyroidism. And other symptoms like muscle weakness and hyperthermia can be observed with the hyperthyroidism. That's why thyroid hormone levels should be strictly controlled in order to prevent the dysfunction of the many of the organs. So today in this video, let us see what are the anti-thyroid agents that can be used to control the hyperthyroidism. So what are the various approaches to control the hyperthyroidism? When our thyroid hormones are excessively released because of the enlargement of the thyroid gland, we can use the radiation therapy, which use the radioiodine, iodine 131, that releases the beta radiation, which causes the destruction of the thyroid globules. Thereby it can decrease the hyperthyroidism. Otherwise, the thyroid gland can be surgically removed such that we can prevent the excessive release of the thyroid hormones. And finally, we can use the anti-thyroid agents, which are going to inhibit the synthesis of the thyroid hormones within the thyroid follicles. So in this video, let us discuss the anti-thyroid agents. So what are the anti-thyroid agents? Based on the type of use, these anti-thyroid agents can be classified into two types: the drugs which are used for the treatment of the hyperthyroidism, otherwise the drugs which are used as adjuvants. Adjuvants are the drugs which are used either pre or post-operatively, either to reduce the size of the thyroid hormone or to prevent what are the side effects during the surgical removal of the thyroid glands. And we can use the beta blockers like the propranolol and nadolol, which are non-selective beta blockers, which are going to block the beta 1 receptors on the cardiac system. Thereby they prevent the cardiac stimulation by thyroid hormones. Similarly, we can use the glucocorticoids like the prednisolone, which can control the inflammation. And calcium channel blockers like the verapamil, which can control the blood pressure. And finally, the iodide. The excessive iodide can be given as a Lugol solution to decrease the size of the thyroid gland such that it can be removed by the surgery. In this way, we can use few of the drugs which are used as adjuvants. But here the Lugol solution can also be used in the thyroid storm in order to reduce the excessive symptoms. Then what are the drugs which are used for the treatment of the hyperthyroidism? So here the antithyroid agents mainly used for the treatment are the thiourines. So now the antithyroid agents are mainly used for the treatment of the hyperthyroidism and they are chemically classified as thiourines. So what are the thiourines? You can see that this is the structure of the thiourea, and if we are going to modify this thiourea and we are going to close the ring either with a 5-membered or 6-membered ring system, then they can produce the thiourines. So here you can see this is one type of drugs where the thiourea is going to be closed with a 6-membered ring system, and this is having the uracil-like structure. So this is nothing but the 2-thiouracil. Similarly, second type of drugs are having the thiourea, which is closed as a 5-membered ring system. And here what are the ring system is the imidazole. So this is nothing but the 2-thioimidazole. So this is the first one, propyl thiouracil. You can observe it is having the uracil structure with a propyl side chain at the 6th position. So this is the 6th propyl 2-thiouracil. Similarly, this is the another structure which is having an imidazole nucleus with a thiol group at the 2nd position. This is nothing but the methimazole. So methimazole is nothing but the 1-methyl 2-thioimidazole. Similarly, second one is the carbimazole. Carbimazole is having the similar structure with a ethyl carboxylate ester at the one of the nitrogen. So that is a carbimazole. So these are the 3 drugs which are used as antithyroid agents. Now let us see how these antithyroid agents can inhibit the synthesis of the thyroid hormones. So this is the plasma and this is the thyroid follicle, and this is the lumen of the thyroid follicle which is having the colloid. Now from the plasma, iodide is going to be absorbed into the follicle where it is going to iodinate the tyrosine residues to produce the thyroid hormones. But here one of the important step is the uptake of the iodide. So one of the pump present here is the NIS, sodium iodide transporter. And another pump is also present on the inner membrane. So this is a pendrin protein which is going to uptake the iodide at the inner membrane. Now the iodide can be transported along with the sodium into the follicles, and within the thyroid follicle the thyroglobulin is present which is attached with the tyrosine residues. These tyrosine residues can be iodinated by the iodide. Now the iodine molecule can attach to this tyrosine residue such that either one iodide molecule can be attached to the one tyrosine residue, otherwise the 2 iodide molecules can be attached to the one tyrosine residue. And this reaction is mediated by thyroperoxidase enzyme, and this enzyme is responsible for the iodination of the tyrosine residues in presence of hydrogen peroxide. Now in presence of thyroperoxidase enzyme, tyrosine residues are going to be iodinated such that they can form the monoiodinated tyrosine residues or diiodinated tyrosine residues, which we have represented here with the letters M and D. Now this thyroglobulin can be secreted into the thyroid follicle along with the monoiodinated and diiodinated tyrosine residues. But within the thyroid follicle, one of the enzymes is the lysosome, which is responsible for the dissolution of these thyroid globulins to release the free iodinated tyrosine residues. And in the next step, thyroglobulin can undergo the endocytosis and it can be present in the lysosome, which produce the cleavage of these tyrosine residues. Now here monoiodinated tyrosine as well as diiodinated tyrosine can be combined. Otherwise, one molecule of the diiodinated tyrosine and another molecule of the diiodinated tyrosine can be combined. So when the 2 molecules of the diiodinated tyrosine residues are going to be joined, they can produce a T4 which is going to be secreted into the plasma. Similarly, a monoiodinated and a diiodinated tyrosine residues can produce a T3 which can be secreted into the plasma. In this way, T4 and T3 are going to be secreted into the plasma from these iodinated tyrosine residues. Now let us see what is the action of these thiourines. Thiourines can inhibit one of the important crucial steps. They can inhibit the thyroperoxidase enzyme activity. By inhibition of this enzyme, they can inhibit the iodination of the tyrosine residues, which inhibits the biosynthesis of the thyroid hormones. But peripherally, the T4 can also be converted to T3, which is going to be blocked by one of the drug PTU, propyl thiouracil. So propyl thiouracil can inhibit the conversion of the T4 to T3 within the peripheral tissues. Now already we have seen that for synthesis of the thyroid hormones, two important molecules are required. One is the iodide and second is the tyrosine. This tyrosine can interact with the iodide in presence of the thyroperoxidase enzyme which undergoes the iodination. But this step is a free radical mechanism. Initially, iodide is converted to iodide free radical and this reaction is mediated by thyroperoxidase enzyme in presence of hydrogen peroxide. And the same enzyme will convert the tyrosine into the tyrosine free radical. You can observe the hydrogen is going to be removed and a tyrosine free radical is going to be produced. Now this tyrosine free radical as well as the iodide free radical can be combined such that they are going to produce the iodinated tyrosine. So this is the monoiodinated tyrosine. In this way they can also prepare the diiodinated tyrosine. So here thyroperoxidase enzyme is important for the iodination of the tyrosine residues which is blocked by thiourines. So thiourines are going to inhibit the iodination of the tyrosine residues. What are the side effects? These antithyroid agents can produce few of the common side effects like the headache, nausea and vomiting, joint pains. And apart from these common side effects, they can produce the two important side effects. One is the neutropenia and another one is the agranulocytosis. This neutropenia, the decrease in the neutrophil count can produce few of the symptoms in the patients such as fever, sore throat and chills. Similarly, agranulocytosis can produce the rapid heartbeat and jaundice in the patients. So whenever these two side effects are observed, the antithyroid agents should be carefully given. So that's about the antithyroid agents. Propyl thiouracil, methimazole and carbimazole are the antithyroid agents which are belonging to the thiourines. Propyl thiouracil is having the uracil structure, whereas carbimazole and methimazole are having the thioimidazole ring system. These drugs are going to inhibit the iodination of the tyrosine residues by inhibition of the thyroperoxidase enzyme within the thyroid follicles. But propyl thiouracil can also inhibit the conversion of the T4 to T3 into the peripheral tissues. But still propyl thiouracil can produce a hepatotoxicity, so it is somewhat toxic compared with the carbimazole and methimazole. So that's about these antithyroid agents. Hope you have enjoyed this video. If you like this video, please subscribe to our channel, share this video with your friends, post your comments in the comment box. Thank you for watching this video. Hi everyone.
So I hope it was interesting. Now is the time to go for the next topic, and the next topic is radioiodine use in the treatment of hyperthyroidism. Introduction, as you know, the radioiodine is effective treatment in gravis hyperthyroidism and in toxic nodular goiter. It's part of nuclear medicine. Radioiodine is administered orally as sodium iodide in solution or capsule. The radioiodine is rapidly incorporated into thyroid gland, and its beta emission results in extensive local tissue damage. The net effect is ablation of thyroid function over a period of 6 to 18 weeks. Radioiodine for treatment of hyperthyroidism will be reviewed now. But first, we have to know the indications. Number one, gravis hyperthyroidism. And usually it resulted in either euthyroid status or to hypothyroidism sometimes, and if the patient pushed into hypothyroid, definitely the best option is to use levothyroxine as a replacement, and toxic adenoma or toxic multinodular goiter, depending upon patient preference, either radioiodine therapy or surgery can be considered in the treatment of choice for these conditions. However, patient can now be managed if preferred or necessary for other reasons with long-term thionamide drugs, as we mentioned before. What are the contraindications and precautions for radioactive iodine ablation? Pregnancy and breastfeeding. Pregnancy and breastfeeding are absolute contraindication to radioiodine therapy. Radioiodine should not be given for 6 to 12 weeks after cessation of breastfeeding to ensure that radioiodine will not be actively concentrated in breast tissue. Please, this is very important in the clinical practice. Fetal thyroid tissue is present by 10 to 12 weeks and would be destroyed by radioiodine, potentially resulting in cretinism. A pregnancy test should be obtained in women of childbearing age before the administration of radioiodine. Rarely, radioiodine is given inadvertently to a pregnant female. The infant may be normal hyperthyroid due to radioiodine-induced increase in maternal thyrotropin receptor antibody level, which in turn affect fetal thyroid function or hypothyroidism, depending on when during the pregnancy the exposure occurred. Each possibility should be considered and appropriate action taken immediately after delivery in select centers which with expertise. Fetal thyroid function may be assessed in utero by percutaneous umbilical vein sampling after 20 weeks of gestation. Thyroid eye disease. Radioiodine therapy compared with thionamide or surgery is associated with a twofold increase in the development or worsening of thyroid eye disease. The changes are often mild and transient, and at least in patients who have mild or no eye disease before therapy, but may be more significant in patients with more severe eye disease. Moderate to severe thyroid eye disease, we consider moderate to severe or sight-threatening thyroid eye disease a contraindication to radioiodine therapy. Thionamide or surgery are the preferred option for such patient, while not recommended patients who refuse surgery and who have had adverse reaction to thionamide may need to be offered radioiodine therapy with glucocorticoid coverage. Mild active thyroid eye disease, radioiodine should be used with caution in patients with active mild thyroid eye disease and risk factor for deterioration, including smoking, high baseline serum concentration, and or T3, e.g. more than, for example, 300 plus, or high antibodies level. While some experts do not treat such patients with radioiodine in one randomized trial, no patient who received a course of oral prednisolone following radioiodine developed new or progressive thyroid eye disease, while 15% of patients who did not receive steroid had new or progressive thyroid eye disease. Thus, in patients with mild eye disease, but risk factor for progression, concurrent administration of glucocorticoid should be administered to prevent deterioration of eye disease. What is our usual approach to the treatment? The following approach to administering radioiodine is consistent with American Thyroid Association for management of hyperthyroidism. Verify negative pregnancy test, usually 48 hours prior to treatment of radioiodine. pre-treatment with thionamide. The rationale for pre-treatment with methimazole include the following. There may be transient exacerbation of hyperthyroidism after radioiodine, which eliminated by pre-treatment. Methimazole returns thyroid function to normal somewhat more rapidly than radioiodine, which can be important for patients who are not tolerating the symptoms of hyperthyroidism or who have comorbidities that make them more vulnerable to effect of hyperthyroidism. In one study, for example, thyroid function was normal at a mean of 5.7 weeks after methimazole treatment, while in another study, the mean level of thyroxine T4 was still slightly above the normal, 7 weeks after radioiodine. This slightly shorter interval to achieve euthyroidism should not be considered a reason for pre-treatment in all patients, since the side effect and potential toxicity from methimazole are significant. Hyperthyroidism is controlled by 12 weeks in 97% of patients taking methimazole, while 10 to 20% of patients receiving single dose of radioiodine failed treatment altogether. There is disagreement about the benefit of thionamide pre-treatment in patient planning for radioiodine therapy. Meta-analysis of 14 randomized trials, adjunctive use of thionamide administration in week before, during, or after radioiodine therapy increased the risk of treatment failure and reduced the risk of hypothyroidism. However, patients who were pre-treated with thionamide had lower incidence of biochemical and clinical hyperthyroidism for several weeks after radioiodine therapy. Candidate for pre-treatment, radioiodine can be administered as initial therapy for hyperthyroidism without methimazole pre-treatment in most patients with hyperthyroidism, especially if they are receiving adequate therapy with beta blocker. However, some patients, particularly older patients and others who are more susceptible to the effect of hyperthyroidism, can be the first treated with methimazole until euthyroidism is achieved. We prefer to pre-treat with the methimazole in the following patient: if the patient has are elderly, more than 60 or 65 of age, and others with comorbidities such as coronary artery disease, atrial fibrillation, heart failure, or pulmonary hypertension, patients with severe thyrotoxicosis who are not tolerating the symptoms of hyperthyroidism, especially if on adequate doses of beta-blocking drugs, while pre-treatment prolongs the period of intensive treatment if shortens the period during which patients have many hyperthyroid symptoms. What is about the administration? In the absence of definitive data to support specific treatment regimen, usually prefer pre-treatment with methimazole for 4 to 6 weeks before radioiodine. Radioiodine can be administered once serum free T4 and total 3 or free T3 concentration are in normal range, or after symptoms have subsided. Our practice usually to stop methimazole 3 days before and then restart methimazole 3 days after radioiodine is given to allow better control of thyroid function post-radioiodine administration. Methimazole is then tapered or stopped as thyroid function normalized, usually between 4 and 18 weeks following therapy, as determined by thyroid function testing and reduction in goiter size. What about the choice of thionamide? As we mentioned before, either methimazole or second one, carbimazole, is the preferred choice. There is controversy about PTU or propylthiouracil more likely to result in treatment failure than pre-treatment with methimazole. And this is approved by meta-analysis, did not find difference between two, but another meta-analysis, did not find difference. So there is controversy in this status. When to stop methimazole, very important. Please, as per radiology instruction or radiologist instruction, methimazole should be discontinued before radioiodine treatment in order to avoid impairing the efficacy of radioiodine in a randomized trial that compared stopping or continuing methimazole in 75 patients. Radioiodine treatment was successful in 61% of patients in whom the drug was stopped 8 days before radioiodine was administered. Most studies suggest that stopping 2 to 3 days before radioiodine is optimal. Comparison of diagnostic and therapeutic radioiodine kinetics in 316 patients treated with radioiodine who did not receive pre-treatment before therapy or in whom it had been stopped for 1 to 2 days, found that alternation in uptake curves and radioiodine half-life were restored to normal 2 days after discontinuation of the thiomazole, either methimazole or carbimazole. And that the success rate of treatment was 87%. Another study shows that thionamide stopped 2 versus 7 days prior to radioiodine, post-radioiodine free T4 level were higher in 7-day group compared with 2-day group, while 24-hour radioiodine uptake and outcome at 6 months and 1 and 2 years were identical. Another study found no increase in post-radioiodine therapy thyroid hormone concentration when carbimazole was held for only 3 days prior to radioiodine administration. When to restart, our usual recommendation as per guidelines to restart methimazole 3 days after radioiodine is given to allow better control of thyroid function. Post-radioiodine administration, resumption of thionamide therapy 3 to 7 days after radioiodine administration has been shown to result in less post-therapy rebound hyperthyroidism, while a post-radioiodine increase in thyroid function will not necessarily occur if patient was treated with methimazole due to old age or cardiovascular morbidity. Resuming methimazole to avoid rebound hyperthyroidism and continue it until radioiodine has resulted in hypothyroidism or euthyroid. Patient unable to take thionamide in selected patient with Graves' disease in whom more rapid normalization of thyroid function is essential, but who are allergic to thionamide, saturated potassium iodide SSKI given daily beginning 1 week after radioiodine normalized thyroid function several weeks earlier than in patient given radioiodine alone. Low iodine diet, while the radioiodine uptake can be increased by following a low iodine diet, this is usually not recommended for patients with hyperthyroidism whose uptake are frequently quite high on a normal iodine diet. Avoiding iodine-containing supplementation include most multivitamins for a week prior to treatment, however, may increase uptake and allow for lower administrated doses of radioiodine. What is the role of glucocorticoid in patients with thyroid eye disease? Radioiodine can cause development or worsening of thyroid eye disease more often than thionamide or surgery. Glucocorticoid given concurrently with radioiodine may prevent worsening of eye disease. My thyroid eye disease with risk factors for patient. This is very important. Please, if the patient with eye disease and it is active, use of steroid is recommended orally. And for patient with active mild thyroid eye disease who have risk factor for progression like smoking, high baseline serum concentration of T3 or high thyroglobulin antibodies, and who are being treated with radioiodine administration of steroid like prednisolone daily starting 1 to 3 days after radioiodine and tapering the discontinuation within 6 to 8 weeks. This is the usual recommendation. If the radioiodine it is administered to patient with risk factor for thyroid eye disease, careful monitoring for development or progression of eye disease is necessary. My thyroid eye disease without risk factors for patient with active my thyroid eye disease without risk factor for progression, the need of concurrent administration of steroid glucocorticoids is uncertain. In the absence of major contraindication, administration of steroid to prevent exacerbation of thyroid eye disease is recommended. Some experts do not treat patients with mild thyroid eye disease with radioiodine also. But again, to be in safe side, use of steroid is recommended. The dose and duration of treatment varied within the individual studies. In 2 trials, the initial dose of prednisolone was 0.4 to 0.5 milligram per kg body weight, initiated 2 to 3 days prior to radioiodine, continued for 1 month, and then for tapering down. What about moderate to severe thyroid eye disease? Radioiodine is contraindicated in patients with moderate to severe sight-threatening thyroid eye disease, while not recommended. Radioiodine with concomitant administration of glucocorticoid can still be considered in patients who refuse surgery and who had adverse reaction to thionamide, or it can be considered after the patient has been stable for at least a year on thionamide. There are few data evaluating the impact of radioiodine with glucocorticoid on progression of moderate to severe thyroid eye disease. Smoker without active thyroid eye disease, cigarette smokers who receive radioiodine have a high incidence of new or progressive thyroid eye disease. In cigarette smoker without thyroid eye disease, there is no evidence for or against using prophylactic glucocorticoid to prevent the onset of eye disease. If smokers with Graves' disease are treated with radioiodine, some guidelines or some opinion to administer concurrent steroid unless there is contraindication to use glucocorticoid also is recommended. Of note, glucocorticoid reduce the effective thyroid half-life of radioiodine by increasing renal plasma iodine clearance. However, there are no reports that addition of glucocorticoid reduce the overall effectiveness of radioiodine treatment of hyperthyroidism status. Other therapies to enhance the efficacy of radioiodine or to reduce the exacerbation of hyperthyroidism that may occur after radioiodine are not recommended. One therapy that has been evaluated as adjuvant in radioiodine therapy is lithium. Lithium may prolong retention of radioiodine within thyroid gland, which could increase the effectiveness of radioiodine therapy. What is the proper dose of radioiodine therapy? Most experts advocate radioiodine dose that result in hypothyroid. There is debate, however, over whether the dose of radioiodine should be fixed or individualized based upon the size of the thyroid gland and 24-hour radioactive iodine and turnover. Usually, individualization, the radioiodine dose based upon the size of thyroid gland and 24-hour radioiodine uptake. The dose is calculated based on milliquery or microquery, or MBQ of thyroid tissue to be delivered, and this is usually calculated by radiologist. Low versus high. Primary goal of radioiodine therapy in Graves' disease is to cure the hyperthyroidism by rendering the patient hypothyroid. In the past, it was controversial whether radioiodine should be given in a sufficient dose to induce hypothyroid or a lower dose in attempt to achieve euthyroid status. However, due to high failure rate associated with lower doses designated to leave patient euthyroid, most experts advocate radioiodine dose that result in hypothyroid. Hypothyroidism is less common initially after radioiodine treatment. Toxic adenoma, toxic multinodular goiter. Patients who develop hypothyroid usually do so because uptake was not suppressed in the extranodular tissue or because the coexistent chronic lymphocytic thyroiditis. In Graves' disease, as we mentioned, radioiodine used to treat patients. The high dose therapy is about 150 to 200 micro CI per gram. This will cure the hypothyroidism, and in most patients will induce hypothyroid in 12 to 18 weeks. In the practice, I see some patients maybe they are not having hypothyroid, but this is the minority. They will stay in euthyroid status. But majority of the cases, they have hypothyroid and they need definitive replacement with levothyroxine lifelong. Administration, much higher doses is not associated with higher rate of cure, but may be used in patients who are being retreated after one or more treatment failure. So this is to convey the message, even after the first dose of radioactive iodine ablation, maybe there is chance of relapse, and after proper assessment, 6 to 12 months after that, if there is still hyperactive or hyperthyroidism, maybe second dose can be administered, and this is the way, or this is the time to give a higher dose, as you see. Toxic adenoma, toxic multinodular goiter, the dose of radioiodine ablation here is approximately 200 micro CI per gram. And here is the video to conclude or to summarize, what we are talking about radioiodine ablation. Please concentrate.
Hey guys, welcome to Endocrine Pharmacology. We are studying thyroid inhibitors, and in this video we will see radioactive iodine or iodine 131. So let's start. It is commonly available as solution which is given orally. After absorption, it goes to thyroid gland. The radioactive iodine accumulates in thyroid follicle same as stable isotope does. Talking about mechanism of action, they emit beta particles which penetrate from 0.5 to 2 millimeters deep and destroys follicular cells from inside. The cells undergo pycnosis, necrosis, and there will be eventual fibrosis of the gland. The process is slow and takes 2 to 3 months till hyperthyroidism is completely controlled. The good thing is there is minimal injury to surrounding tissue. Apart from beta particles, it also emits gamma rays which passes through the tissue and can be measured from external detector. This property is used for diagnostic purpose. Half-life of radioactive iodine is about 8 days. Now let's talk about uses of radioactive iodine. Therapeutically, it is used for hyperthyroidism, for example, Graves' disease, toxic nodular goiter, and thyroid cancer. Diagnostically, it is used in low doses to identify some thyroid conditions. Now let's talk about pros and cons of radioactive iodine. First, pros. In contrast to surgery, radioactive iodine can be given on outpatient basis. It is cheaper and it does not involve some of the risks that are associated with surgery like injury to parathyroid gland and recurrent laryngeal nerve. And of course, there won't be any scar on your neck, so it is good for cosmetic point of view also. Coming to the cons. There is risk of hypothyroidism as side effect. It takes long for 2 to 3 months till hyperthyroidism is completely controlled. And it is not suitable for children as such children are more likely to develop hypothyroidism later in their life. It should also be avoided in pregnant lady because it may destroy fetal thyroid tissue. So that was the radioactive iodine. Now let's have a quick summary. It is commonly available as solution and is given orally. Mechanism of action includes emission of beta particles which destroy thyroid tissue and gamma rays which is used for diagnostic purpose. Uses are hyperthyroidism like Graves' disease, toxic nodular goiter and thyroid cancer. And also it is used for diagnostic purpose also. The pros are, the therapy is simple, convenient and can be given on outpatient basis. It is cheap and there is no surgery related risks. For example, injury to parathyroid gland and recurrent laryngeal nerve, and there is no scar. The cons are hypothyroidism. It takes 2 to 3 months for effects to develop. It cannot be used in children as there is higher risk of hypothyroidism in later life and in pregnant lady because of destruction of fetal thyroid tissue. So that's it for this video. If you have any doubt or suggestions, please drop it in comment section below. And don't forget to subscribe because lots more to come. Thanks for watching. See you in next video.
Let's now go for the post-treatment precaution. I hope the video was easy to understand. To summarize, the American Thyroid Association, ATA, published recommendation on radioiodine safety for patient, families, caregiver, and public after radioiodine therapy. The recommendations are based upon clinical experience and available data. Data on long-term outcome are limited, and the dose of radioiodine administered for treatment of hyperthyroidism are lower than those used to treat thyroid cancer. The majority of patients with hyperthyroidism can be treated with 131 iodine in the outpatient setting. Patient receiving dose of 55 MCI for hyperthyroidism can typically be released without exceeding dose limit established by the Nuclear Radiology Commission. But again, what to do in the household contact after the patient receiving radioiodine ablation. Patients who receive radioiodine have the potential to expose their home and household contact via saliva, urine, or radiation emitting from their body. So again and again, if there is risk to give radiation to the people in the home. So that's why we have to follow some precaution. They should be instructed to avoid the following during restricted period. Number one, sharing cups or utensils, sleeping in the same bed with another adult, or pregnant lady, infant, child, sexual contact, close contact with children, and pregnant female. The period of post-treatment precaution, usually between 7 to 10 days, up to 14 days, and this is depending on the radiologist, how much the dose is given, and what is the status of the patient. Future pregnancy should be delayed, as we mentioned, at least 6 months after radioiodine therapy to ensure that hyperthyroidism is successfully cured and hypothyroidism corrected prior to conception. Some experts suggest delaying pregnancy for a year or more because TRAb level increase after radioiodine and remain elevated for a year, which theoretically would increase the risk of fetal or neonatal hyperthyroidism. However, unintended pregnancy after radioiodine treatment and during this interval should be allowed to proceed to term. Congenital anomalies do not appear to be more common in women treated with radioiodine. The gonadal dose is approximately 3 rad, similar to that for hysterosalpingiography or barium enema. Monitoring after radioiodine. All patients require monitoring for hypothyroidism or persistent hyperthyroidism. Most patients have normalization of thyroid function test within 4 to 10 weeks. Hypothyroidism may occur as early as 4 weeks. Hypothyroidism should be avoided as this is risk factor for worsening thyroid eye disease. Measuring serum free T4, total T3, TSH at 4 to 6 weeks after radioiodine, and then at 4 to 6 weeks interval thereafter, depending upon the result of prior testing and change in thyroid size. If patient becomes and remain euthyroid for 6 months, serum TSH should be measured at 6 to 12 months interval for patient lifetime because of ongoing occurrence of hypothyroidism after radioiodine therapy. If patient becomes hypothyroid, the thyroid hormone should be initiated and dose initially adjusted to maintain normal free T4 level. Once euthyroidism is achieved on a stable dose of thyroid hormone replacement, TSH can be measured annually. If patient has persistent hyperthyroidism, monitoring of thyroid tests should continue at 4 to 6 interval. With additional therapy is planned. The principal test used to follow the immediate effect of treatment of hyperthyroidism is the serum free T4 concentration measurement of measurement of serum TSH can be misleading in early follow-up period. So in the early follow-up, don't concentrate on TSH, look for T4 and T3 because it can remain low for weeks or even months, even when the patient is biochemically euthyroid or even hypothyroid, with serum free T4 values well within or even below the normal range. When both TSH and free T4 are low, measurement of serum T3 is necessary to distinguish between persistent hyperthyroidism, which has T3 elevated, and transient central hypothyroidism associated with recovery of hypothalamic pituitary thyroid axis after treatment of hyperthyroidism. So very important to measure T3. It will differentiate between the two. Once steady state condition assured, measurement of serum TSH is required to assess the efficacy of therapy. Percentage of patients with Graves' disease who become hypothyroid within the first year after treatment varies directly with the dose of radioiodine. Hypothyroidism occurs in approximately 80% of patients receiving high dose of therapy. and 10% of patients receiving low-dose therapy. The first one example 160 and the second one is 80. Hypothyroidism that develops within the first year may be transient. In a study of 260 patients who received radioiodine therapy for Graves' hypothyroidism, for example, 67 developed hypothyroid within the first year after treatment. The hypothyroidism was transient in 58%. However, 70% of those with transient hypothyroidism became permanently hypothyroid in subsequent to 11 years. Most patients who become euthyroid soon after radioiodine therapy develop hypothyroidism at rate of 2 to 3% per year. This occurs because of the late effect of radiation and lymphocytic infiltration and destruction of thyroid tissue and process similar to chronic lymphocytic Hashimoto thyroiditis. Persistent hyperthyroidism, again, as we mentioned before, 10 to 20% of patients fail the first radioiodine treatment. In meta-analysis of more than 4,000 patients with Graves' disease, treatment failure was correlated with male sex administration of radioiodine more than 6 months after diagnosis, prior use of thionamide, 24-hour radioiodine uptake more than 60%, and thyroid volume more than 35.77 ml. Patient with treatment-resistant Graves' disease, persistent hyperthyroidism 6 months following radioactive administration of second dose of radioiodine is recommended. If the response to the first dose of radioiodine has been minimal, large goiter persists, second dose can be administered earlier, for example, after 4 months. Patient with rapid thyroid iodine turnover, whose 2 to 4 hour radioiodine uptake is higher than 24-hour radioiodine uptake, more likely to have poor response to radioiodine treatment. In one study, the initial cure rate was 28% in patients with high turnover and 66% in patients with normal turnover. These patients with high turnover required 1.5 to 2 times the radioiodine dose to achieve a cure. In addition, patients with large isoechoic gland that more colloid, more likely to have radio-resistant than hypoechoic gland, which have more densely packed cells. Adverse event expected with a radioactive iodine, usually quite safe, but hypothyroidism, as we mentioned, what we are observing, usually radiation thyroiditis occur in 1%. The incidence of radiation thyroiditis after radioiodine therapy. Radiation thyroiditis can cause relatively severe thyroid pain that can last 2 to 3 weeks and may be associated with the exacerbation of hyperthyroidism unless hormone stores were first depleted within thionamide therapy. Non-steroidal anti-inflammatory drug usually sufficient for analgesia, but prednisolone may be required in severe cases. Rebound hyperthyroidism weeks to months following radioiodine therapy. There may be recurrent, albeit transient, hyperthyroidism likely due to radiation-related increase in antibodies. This should be distinguished from radiation-related thyroiditis, which typically develops within 1 to 3 weeks of radioiodine therapy. If rebound hyperthyroidism develops, methimazole should be restarted and continued until thyroid function normalizes. Radioiodine and thyroid eye disease. Most but not all studies of patients with Graves' disease suggest that radioiodine therapy associated with appearance or exacerbation of thyroid eye disease more often than treatment with thionamide or surgery. These changes are often mild and transient, at least in patients who have mild or no eye disease before therapy. The exacerbation of thyroid eye disease after radioiodine is thought to be due to increase in level of antibodies following radioiodine treatment that persist for up to 1 year. In contrast, antibodies level tend to fall after surgery and during thyroid therapy. What about the risk of cancer? The cooperative thyrotoxicosis therapy follow-up study group followed more than 35,000 patients from 26 centers. Cancer mortality after radioiodine therapy. Analysis data shows no increase overall cancer mortality. What about gonadal function? Radioiodine in doses used to treat hyperthyroidism does not cause infertility or congenital anomalies in offspring or treated patient. Total dose to the test average 39 micro-GY per MBQ. Radioiodine administration results in transient reduction in serum testosterone concentration without change in serum FSH, improves sperm mortality, and no change in sperm concentration or morphology. What about peritoneal myxedema? Radioiodine may be associated with new or worsening infiltrative dermopathy. This is a quick video to summarize what we are talking about. Please concentrate.
Hello, my name is Dr. Margaret McLean, and I'm a nuclear medicine physician in the Department of Nuclear Medicine at Kaiser Permanente Santa Clara Medical Center. This presentation has been created to tell you about nuclear medicine and radioactive iodine treatments that may be needed. Radioactive iodine therapy, or iodine-131 therapy, has been used as a treatment for thyroid cancer or hyperthyroidism since the 1940s. It has an excellent safety record. Because iodine is used by the thyroid gland to make thyroid hormone, we are able to use radioactive iodine, or I-131, as a therapy for well-differentiated thyroid cancers or benign thyroid disease such as hyperthyroidism secondary to Graves' disease or a toxic thyroid nodule. When you meet with your nuclear medicine physician, he or she will explain more about how radioiodine therapy works, the precautions that need to be taken, and next steps. Radioactive iodine is taken by mouth and collects in any remaining thyroid tissue, including thyroid cancer cells that have spread to other places in the body. Since only thyroid tissue takes up iodine, the radioactive iodine treatment destroys thyroid tissue and thyroid cancer cells without harming other tissue. As with any treatments, radioactive iodine may cause side effects. The extent of side effects largely depends on the radioactive iodine treatment dose level. Low-dose therapy may not cause any side effects. Most patients experience at worst relatively mild side effects, but everyone responds differently to treatment. Some patients may experience tenderness and mild swelling of the neck, nausea, dry mouth, or a temporary change in the taste sensation. Women are discouraged from becoming pregnant for a minimum of 6 months following radioactive iodine treatment. Female patients may be asked to take a pregnancy test. Your nuclear medicine physician will discuss these possibilities with you. The best way to manage side effects is to know what to do before they occur, and your care team will work with you to prepare for and resolve any problems. There is some flexibility as to when the radioactive iodine treatment can be done. This will allow you to have treatment when it is most convenient for you. When you come in for your treatment, you will meet with your nuclear medicine physician, who will again review the radiation safety precautions and check that all necessary arrangements have been made at your home and at work. The radioactive iodine therapy dose comes in a capsule pill form, and you will swallow the capsule with a drink of water without touching it to your skin. You may then go home. Your doctor will place a small yellow sticker on your Kaiser card indicating the date of your treatment and the dose of iodine-131 given to you. You will need to keep this sticker attached to your Kaiser card for 3 months, and remember to keep the card with you at all times. If you are not already taking thyroid hormone, your doctor will prescribe the medication to be filled at the local pharmacy. The medication is a synthetic version for thyroid hormone and takes the place of natural thyroid hormone once the thyroid has been removed. For patients who are being treated with radioactive iodine for thyroid cancer, about 1 week later you will return to the nuclear medicine department to have another whole body scan called a post-therapy scan. This is done to determine exactly where the radioactive iodine remains in your body. The scan will serve as a baseline for future comparison. Following treatment with radioactive iodine, your body will contain radioactivity levels that will decrease every day. For this reason, some precautions will be needed for several days after treatment to minimize radiation exposure to those around you. Your nuclear medicine physician will create an individually tailored program for you. The details will depend on the amount of radiation required for your treatment and on your lifestyle, both at home and at work. The written plan will help guide you in taking care of yourself and protecting those around you, especially young children and pregnant women, and you will be given detailed instructions to minimize the time you spend in close contacts with such people. We ask that you avoid areas such as schools, workplace, or places of religious gathering. Your doctor will also discuss with you how long you should remain in your room and sleep in your own bed if you are living with others. If there is no other person in your residence, you can continue with your normal activities of daily living and do not need to restrict yourself to your own room. Only when others are at home with you simultaneously do we request that you remain in your own room as much as possible. The majority of radioactive iodine not taken up for treatment will be excreted in the urine in the first 24 to 48 hours. In order to reduce radiation exposure to your salivary glands and bladder, we encourage you to drink at least 1 glass of water every hour and urinate every 2 hours when you are awake. Please flush the toilet twice after each use with the lid down. If urine is splashed outside of the toilet, clean the spill 3 times with toilet tissue or flushable wipes and dispose down the toilet. Men must sit to urinate. Please discuss with your physician if you're currently using sanitary pads, tampons, and/or diapers. A minimal amount of radioactivity is also excreted in the sweat. At the end of your treatment period, please wash your clothes and linens separate from the rest of the family's laundry. A small amount of radioactivity is excreted in the saliva. Use separate eating utensils and toothbrushes. There is no need to use disposable utensils. Do not cook for others. Please let us know if you will have any travel plans in the next 3 months, as a special letter may be given to you to facilitate security clearance at the airport. Lastly, although we ask that you minimize contact with others, you're not in quarantine. A quick hug and a dry kiss are always fine. Although precautions are needed to avoid unnecessary exposure of radiation to others, radioactive iodine is a safe and effective therapy for treatment of thyroid cancer or hyperthyroidism. We hope this video has given you a better understanding of what to expect in the weeks following your radioactive iodine treatment and the role nuclear medicine will play. We look forward to seeing you in the nuclear medicine department. Thank you.
Okay, I think it's the time now to go for break, half an hour. We'll be back inshallah at 6:15. So break till 6:15. Welcome again, everyone. Let's continue our journey today in the second day of thyroid course. And my topic now is thyroid storm. And thyroid storm, one of emergencies that we are facing in endocrinology field. Let's start by this scenario. We have a 22-year-old female evaluated for tachycardia, fever, agitation, and confusion for the last 3 days after she went laparoscopic cholecystectomy for acute cholecystitis. And medical history is significant for type 1 diabetes mellitus, well controlled on basal bolus insulin, and Graves' disease previously treated with methimazole. Methimazole was discontinued 6 months ago when she was considered to be in remission. Medication are insulin, glargine, and insulin aspart. Physical examination, she has fever, temperature is about 39 degrees centigrade, blood pressure is 95/50, as you see in the lower side. Pulse rate is 132. Irregular respiration rate is 24 per minute. Patient is confused and appears flushed and diaphoretic. Lid lag is noted. Thyroid gland is diffusely enlarged with browy, audible. Her deep tender reflexes are brisk. There is fine tremor of her hand. Examination is otherwise normal. Thyroid function test and other work up are pending. What about the outlines that we would like to discuss? We have to know thyroid storm epidemiology, risk factors, clinical features, scoring system diagnosis, treatment, and then we'll go for conclusion. That a thyroid or thyrotoxic storm is an acute life-threatening syndrome due to exacerbation of hyperthyroidism. Thyroid storm may be the initial presentation of thyrotoxicosis. It is a rare disease and occurs in about 0.2 cases every 100,000 population. It is now an infrequent condition because of earlier diagnosis and treatment of thyrotoxicosis. Mortality rate in the range of 8 to 25% in modern series. The pathophysiology: increase in free thyroid hormone, decrease in thyroid hormone binding protein, increase sensitivity of peripheral tissues to thyroid hormone, sympathetic nervous system activation, which enhance the response to catecholamines. What about the precipitating factors? Discontinuation of antithyroid medication is number 1. Number 2, infection. Number 3, acute illness. Number 4, thyroid surgery and non-thyroidal surgery. Then thyroid bed trauma, radioiodine therapy or iodinated contrast, pregnancy, particularly during labor delivery. What is the expected, or what are the expected clinical features? We see that maybe we are seeing some symptoms related to thermoregulatory system like hyperpyrexia, large insensible fluid loss, nervous system confusion, seizure, coma, cardiovascular including accelerated tachycardia more than 130, atrial dysarrhythmia, heart failure, gastrointestinal symptoms including nausea, vomiting, and diarrhea, hepatic like hepatic dysfunction, jaundice, psychiatric like severe agitation, emotional lability, and maybe we are seeing goiter also. What are the expected laboratory findings? Low TSH, high free T4, and or T3 in primary hyperthyroidism. High or normal TSH and high FT4 in central hyperthyroidism. So hyperthyroidism also can be from the pituitary gland. and it is called central. And in this situation, you will find high T3, high T4, sorry, with TSH. Severity of thyroid hormone is not mandatory in the storm, leukocytosis or leukopenia, mild hyperglycemia, mild hypercalcemia also observed. Diagnosis, clinical symptoms, severe and life-threatening symptoms involve usual diagnostic measures of thyrotoxicosis, elevation of free T4 or T3 and suppression of TSH, history of hyperthyroidism, physical finding of an enlarged thyroid or hyperthyroid eye finding is helpful in suggesting the diagnosis. We have a scale with collecting which calculate the points to give the probability of thyroid storm, and it is called Borch-Wartofsky point scale and includes the following items: thermoregulatory dysfunction, and the temperature here between 37.2 to 37.7 will be 5 points, and will go down 10 points, 15, 20, 25, and 30 points according to the scale you are seeing. What about the heart rate? Heart rate less than 90. If we are observing 90 to 109, 5 points, and we increase the points according to the heart rate as you are seeing the scale in front of you. Then we look for GIT and hepatic symptoms. If it is severe, unlike unexplained jaundice, you will give 20. Moderate symptoms, diarrhea, nausea, vomiting, abdominal pain, 10 points, and absent 0 point. Heart failure symptoms, severe pulmonary edema, moderate basal crackles, mild pedal edema, and if there is no heart failure, will give again some points as you see. Atrial fibrillation, yes, positive 10, no 0, and precipitating factor, if there is, give 10 points. So if you calculate the points, what we will see, you will see the total calculation to give you a hint. You are dealing with possibility of thyroid storm, or unlikely you are dealing with thyroid storm. If the points less than 25, storm is unlikely. If the points more than 45, thyroid storm is likely. And if it is between 25 to 44, impending storm. What about the diagnostic criteria for thyroid storm of Japan Thyroid Association? They have, again, diagnostic criteria. Maybe it is helpful sometimes just to know and or to have an idea again. Symptoms like central nervous system, fever, tachycardia, congestive heart failure, and GIT symptoms. Diagnosis, combination of the features, exclusion and provisions. So this is another diagnostic tool that can be used, but usually in the practice, we are dealing with the first one, which is the scoring system. I have here a question, 58-year-old female present in ER with confusion. She is found to have raised temperature, tachycardia, hypotensive. Further investigation, she found to be thyrotoxic storm given her presentation. What is the best first line treatment? I want your participation, please, in the chat box. Do you think that A is the proper choice? You will give adrenaline and hydrocortisone. B, beta blocker and PTU, propylthiouracil. 3, adrenaline, PTU, and hydrocortisone. Finally, for beta blocker, PTU, and hydrocortisone. I'm waiting your responses down in the chat box. I will give you a few seconds. Majority of choices here are going with either 2 or 4 beta blocker BTU or 4 beta blocker BTU and hydrocortisone. Let us see the proper answer here. It is 4. It should be combination of hydrocortisone, BTU, and beta blocker. Thyroid storm, as we mentioned, it is a medical emergency that has to be recognized and treated immediately. Admission to ICU is required. It is essential to treat precipitating factors like infections. Major lines of treatment including thionamide drugs like BTU, methimazole, beta blocker, propranolol, esmolol infusion, glucocorticoid like hydrocortisone or dexamethasone, iodine like SSKI or Logol solution also can be used. Treatment of hyperthermia, paracetamol or cooling, correction of dehydration and nutritional deficit, fluid and electrolytes, give glucose, vitamins, also as supportive measures. You need corticosteroid, vasopressor, congestive heart failure management. Antibiotic if there is underlying infection, oxygen therapy if needed also. Treatment is directed against the thyroid gland, inhibition of new hormone synthesis, thionamide drugs like BTU, methimazole, carbimazole, inhibition of thyroid hormone release, iodide, potassium iodide, lithium carbonate also. Treatment directed against peripheral effect of thyroid hormone, inhibition of T4 to 3 conversion can be done with BTU. This is available, or this, I mean the benefit of BTU or advantage available with BTU, but not available with carbimazole or methimazole. Use of steroid, propranolol, iodine, removal of thyroid hormone excess with plasmapheresis or cholestyramine. Antithyroid drug, parathyroxine is preferred over methimazole, carbimazole, since BTU also prevent the conversion of T4 to T3 as we mentioned. So this is the benefit or advantage available or present in BTU but not in methimazole and carbimazole. In case of stomach distension, vomiting, or severe heart failure, medication can be given by intravenous or rectal route. So sometimes rectal preparation in suppository, you can use it if there is severe GI symptoms. Because the iodine could stimulate thyroid hormone synthesis, iodide should be administered an hour after thionamide has been given. This table is summarized what are the medication that is used in STORM. As we mentioned, BTU, the doses is about 500 to 1000 milligram load, followed by 250 milligram every 4 hours. Block new hormone synthesis. Methimazole 60 to 80 milligram daily, block new hormone synthesis. Propranolol beta blocker 60 to 80 milligram every 4 hours. Consider invasive monitoring in congestive heart failure patient. Block T4 to T3 conversion in high doses. Alternate drug esmolol infusion. Iodide saturated solution. 5 drops orally every 6 hours. Do not start until 1 hour after antithyroid drugs. Hydrocortisone 300 milligram intravenous load, then 100 milligram every 8 hours. This is again a scenario. 57-year-old man with Graves' disease develops agranulocytosis while taking methimazole. Methimazole stop and cell count recover, but he develops nausea, vomiting, and present to emergency department. Physical examination showing temperature of 39.4 degrees centigrade, pulse rate of 140, irregular pulse, crackles observed while auscultating the chest, especially in the mid-lung field. 3 T4 and T3 level are 3 times the upper normal limit. He is admitted to intensive care unit and received antibiotic, intravenous propranolol, hydrocortisone, oral potassium iodide therapy. His condition continues to deteriorate at urgent thyroidectomy is planned. The question here, which additional measure could be considered for this patient before thyroidectomy? I need your input, please. Hemodialysis, A. B. Replacement of propranolol with atenolol. C. Plasmapheresis. D. Intravenous immunoglobulin therapy. And E. Initiation of propyl thiouracil. I need your input. I will give you a few seconds. Let's see your answers. We are seeing some with D, some with E. Also, but maybe the majority going with either D or E. Few going with the proper answer, which is plasmapheresis. So what is the role of plasmapheresis? Urgent thyroid surgery. It is a rare situation. You need to go for plasmapheresis if medical therapy is ineffective. A patient develops side effect and contraindication to available therapy. As the severe thyrotoxic patient improve clinically, corticosteroid should be gradually tapered until discontinued. Antithyroid treatment should be continued until euthyroid is achieved. Planning for definitive therapy with either radioactive iodine ablation or surgery also should be kept in our mind. Avoiding common participant, avoid abrupt discontinuation of antithyroid to prevent thyroid storm. Ensure that patients are euthyroid prior to selective surgery, labor, or delivery. I have a video for review. Please concentrate.
Thyrotoxic crisis, more commonly called thyroid storm, is a severe, acute complication of hyperthyroidism. In hyperthyroidism, there's an excess of thyroid hormone, and in thyroid storm, the symptoms and physiologic effects of having excessive thyroid hormones are suddenly magnified. Normally, the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to the circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, where it can exert its effect. T3 speeds up the cell's basal metabolic rate. So as an example, the cell might produce more proteins and burn up more energy in the form of sugars and fats. It's as if the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone reabsorption, thinning out the bones, and then activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase can be really useful when you need a boost to get through the final rounds of a sporting competition, or when you're trying to stay warm during a snowstorm. Now, hyperthyroidism can happen a few different ways. All of them result in too much thyroid hormone in a hypermetabolic state, where cellular reactions are happening faster than normal. The most common primary cause is Graves' disease, an autoimmune disorder where B cells produce antibodies against several thyroid proteins. These autoantibodies include thyroid-stimulating immunoglobulins, which bind to the TSH receptor on the follicular cells and imitate TSH. Another primary cause is toxic nodular goiter, where one or more follicles starts generating lots of thyroid hormone. In some cases, it's because of a mutated TSH receptor that inappropriately keeps these follicular cells active. Regardless of the cause of hyperthyroidism, occasionally a person can develop thyroid storm, which is when the effect of having excess thyroid hormones is suddenly magnified. The exact reason that this happens is unclear, but there are some proposed mechanisms. The first is that there may be more unbound thyroid hormone in the blood, which is the active form of the hormone. The second is that the level of unbound thyroid hormone may be unchanged, but the tissues might become more sensitive to thyroid hormone. Third, the body might become more sensitive to catecholamines like epinephrine or dopamine, which are part of the sympathetic nervous system. Triggers for thyroid storm include stressors like surgery, trauma, infection, or childbirth. Other triggers are abruptly stopping treatment for hyperthyroidism or taking too much thyroid hormones, which is relevant for individuals that have hypothyroidism. The end result is the same, a state of severe hypermetabolism, so all the effects of the excess thyroid hormones on the body are magnified. The symptoms of thyroid storm are mostly an exaggerated version of the symptoms of hyperthyroidism, which include weight loss despite an increase in appetite because of the higher basal metabolic rate, heat intolerance because the body is producing more heat, and rapid heart rate, sweating, hyperactivity, anxiety, and insomnia because of the effects of thyroid hormones on the sympathetic nervous system. In thyroid storm, heat intolerance turns to fever. Hyperactivity and anxiety turn into agitation, confusion, and can go as far as seizures and coma. Cardiovascular symptoms like tachycardia can turn into cardiac arrhythmias and high output cardiac failure. Thyroid storm can be extremely severe and can cause death if it's not quickly recognized and managed. The diagnosis of thyroid storm is usually based on the severity of symptoms and can be confirmed by tests like an ECG to detect a cardiac arrhythmia. Typically, there isn't much of a difference in thyroid hormone levels between hyperthyroidism and thyroid storm. The biggest difference is how the hormone levels affect the various body systems. Treatment for thyroid storm requires intensive supportive care, with various medications like beta blockers to treat symptoms, thionamides to block thyroid hormone production, as well as iodine preparations, glucocorticoids, and bile acid sequestrants. All of these medications are aimed at reducing the amount of thyroid hormone and its effects on the body. If this approach doesn't work, plasmapheresis can be tried. That's where blood plasma is removed, thyroid hormone can also be removed, and the remaining plasma is returned to the person. Alright, as a quick recap, thyroid storm is an acute, life-threatening complication of hyperthyroidism, where the body becomes very sensitive to the effects of excess thyroid hormone. It can cause symptoms like high fever and severe tachycardia, and because of its high mortality rate, medications like beta blockers and thionamides have to be given rapidly.
Helping current and future clinicians focus, learn, retain, and thrive. Learn more.
I hope it was clear, revision. I'll try to share the next lecture. The next lecture is about subclinical hyperthyroidism. If you remember in the morning, in the first presentation, we talked about hyperthyroidism over, but now I will talk about the subclinical hyperthyroidism. There is a quick announcement for the interesting people about endocrinology feed and diabetes. Please follow our Twitter account in front of you, EndoDMOS. It's actually a pure scientific account about endocrinology and diabetes. Some updates, some quick revision about basics in endocrinology and diabetes. So if you are interested, please follow our Twitter account, EndoDMOS, ENDODMOS. So what is the, here, just a quick icebreaker. Patient do not believe I am a real doctor. This one of the doctors, he thinks or he is sad. And the reason patient do not believe that because he has a good hand writing. So just please, for healthcare provider, to have a good handwriting, to make it clear decision in all documentation, prescriptions, it will be great in the clinical field. Subclinical hyperthyroidism definition, epidemiology, causes, clinical presentation, laboratory diagnosis, and management. EndoDMOS, again, is our Twitter account. So what is the definition? Defined biochemically, normal free T4, T3 with low TSH less than 0.5. Term overt hyperthyroidism refers to patient with elevated level of free T4, T3, or both, and subnormal TSH concentration. So this is usually is what we are seeing. The prevalence is about 0.7 to 12.4%, more common in areas of the world with mild to moderate iodine deficiency, more common in female smokers and older population. The etiology, it is the same, like overt hyperthyroidism. We can say that the excessive hormone therapy, exogenous subclinical hyperthyroidism, autoimmune functioning thyroid adenoma, and multinodular goiter, which is called toxic multinodular goiter, or autoimmune process Graves' disease. So the same causes of overt hyperthyroidism is applied here for subclinical hyperthyroidism. This is which mentioned previously, how to classify hyperthyroidism causes. No need for repetition, just to keep it in your mind. We know that thyroiditis, one of the differential diagnosis also, and the usual phases of thyroiditis start by 3 months of hyperthyroidism, followed by 3 months of hypothyroidism, and usually followed by euthyroid status. Again, please, in your life, just do nothing, or it is impossible, is not the proper way. Go for the down, we can say, statement. Just do it. Nothing is possible. Nothing is impossible. Exogenous subclinical hyperthyroidism, 200 million people worldwide taking thyroid hormone. All are at risk of subclinical hyper, whether intentional or unintentional. Many of these patients have hypothyroid and subclinical hyperthyroidism is not the goal of thyroid hormone therapy. Subclinical hyperthyroidism is the goal in some patients, e.g. thyroid cancer, and these patients' benefit of TSH suppression are thought to outweigh the risk of subclinical hyperthyroidism. Endogenous subclinical hyperthyroidism above age of 55, hyperthyroidism due to multinodular goiter was subclinical in 57%. Hyperthyroidism due to Graves was subclinical in 6%. Subclinical hyperthyroidism also occurs in patients with thyroiditis, but again, we know it is a transient period. 63% of clinically euthyroid patients with Graves ophthalmopathy, 4% of those with Graves disease in remission. It may also be seen in patients with early Graves disease prior to the onset of more hyperthyroidism overt. The clinical findings, again, it is identical, or they are identical to patients with overt hyperthyroidism. No clinical if there is, but it is considered mild symptoms. Some patients maybe has no clinical manifestation, and some has mild symptoms, mild tachycardia, tremor, dyspnea, etc. So this is what we are seeing in the subclinical hyperthyroid. Many patients have multinodular goiter with autonomy or autonomous toxic nodular goiter, or they have mild Graves disease. Subclinical hyperthyroidism is associated with an increased risk of AF and postmenopausal women decrease in BND. This is the usual manifestation that may be seen as we discussed before. Again, maybe onycholysis, maybe vitiligo, alopecia, because usually it is associated with other autoimmune diseases, stare, lid lag, lid retraction, ophthalmopathy, also seen. If you are seeing the sclera below the pupil, it means the patient, below the iris, sorry, it means patient has exophthalmos. But if you see above it, it means patient has lid lag. Diplopia also can be seen, either vertical or horizontal. Diagnosis, again, low TSH with normal free T4 and T3. It may occur in the presence or absence of mild symptoms of hyperthyroidism. TSH less than 0.5, TSH should be repeated with free T4 and T3. Because TSH can be transiently reduced, TSH plus free T4 and T3 should be repeated after 1 to 3 months to confirm diagnosis. Once diagnosis of subclinical hyperthyroidism established, the cause should be identified following the same steps what we are doing with overt hyperthyroidism, including antibodies, including uptake scanning, etc. Differential diagnosis, as we mentioned, may be with low TSH, normal free T4, T3, central hypothyroidism may be one of the causes. Non-thyroidal illness, recovery from hyperthyroidism. In normal people of African descent, approximately 3% of healthy Black people have TSH less than 0.4, although it would be unusual for TSH to be less than 0.1. Identifying the cause, measurement of thyrotroporin, thyroid receptor antibodies, TSI or TB2 or TBII or TBI positive confirmed Graves, negative be considered another differential. But again, mild Graves is one of the differential here. Determination of radioactive iodine uptake scan can be initial test or a secondary test in patient with a negative antibodies. If the scan shows one or more focal areas of increased uptake, differential diagnosis include toxic adenoma and toxic multinodular goiter. High uptake is suggestive of Graves. Low or no uptake, maybe you have to think about thyroiditis. I have again an MCQ for you question. I need your participation. Which radiological test patient is undergoing in this photo: CT abdomen, CT neck, bone mineral density, MRI pelvis. I need your input, please. I will give you a few seconds in chat box. Many different answers, C, D, even A. Actually, the correct answer, bone mineral density. So what is the correlation of bone mineral density here with hyperthyroidism? As we know, bone density, this is called bone densitometry. It is essential to screen for osteoporosis, because patients with hyperthyroidism patients are prone to have osteopenia or osteoporosis. Again, maybe you are using ultrasound to look for nodules in postmenopausal women or other patients at risk of osteoporosis. Bone densitometry may be useful in making decision to treat subclinical hyperthyroidism. This is, again, never stop working on yourself. This is a message for all of us to improve ourselves. I have this uptake scan. I need your input. It suggests toxic adenoma, thyroiditis, or toxic multinodular goiter, or Graves' disease. So many answers, B, D, D again, but actually the correct answer, you see homogeneous uptake in whole gland. It means Graves' disease. This is a quick revision, how to differentiate toxic multinodular goiter, multiple nodules in both sides, toxic adenoma, one nodule, Graves' disease, uptake whole gland, or this is what we are seeing in uptake scanning. What is the consequence of subclinical hyperthyroid? The skeleton and cardiovascular system are the major target tissue adversely affected by subclinical hyper, although abnormality in other systems have been reported. Clinical manifestation, I think we discussed, it is the same, to be identical to patients with overt hyperthyroidism, which we discussed before. Increased bone density, increased fracture rate, increased heart rate, cardiac contractility, loss of weight, laboratory finding for lipid profile, alkaline phosphatase, all we discussed before. Progression to overt hyperthyroidism. Progression to overt hyperthyroidism appears to be related to degree of subclinical hyper and underlying disease. The lower TSH, the more chance of complications also. Patient with on T4 replacement treatment of hypothyroidism, dose adjusted to maintain normal serum TSH concentration between 0.5 to 5. Patient with suppressive T4 therapy, patient with thyroid cancer, subclinical hyperthyroid. The goal is the goal of thyroid hormone replacement. In these patients, benefit of TSH suppression are thought to be outweigh the risk of subclinical hyper. Endogenous subclinical hyperthyroidism, patient at high risk for complication, patient at low risk of complications, patient at high risk for complications. including patient with age list more than 65, patient with at risk of cardiovascular disease, postmenopausal female who are at risk of osteoporosis. What should we do here? We have to depend on TSH. If less than 0.1, treat the underlying cause using the medication carbimazole, for example. But if it is in between 0.1 to 0.5, treat especially if there is underlying cardiovascular disease or bone mineral density is low or patient has hyperthyroid symptoms. Again, you can treat if the scan is high. So these are the indications if TSH between 0.1 to 0.5. Asymptomatic patient, especially in the absence of autonomous nodule on scan, in patient with normal bone density, patient who are taking osteoporosis drug to reduce bone turnover, in patient who are taking beta blocker, in observed patient, measure TSH, free T4, T3 every 6 months to have a good monitoring. What about low risk patients, less than 65, pre-menopause? If TSH persistently less than 0.1, treat the underlying cause, especially again if the uptake is high. Thyroid radioactive iodine scan shows high uptake or patient is symptomatic. Observation is another approach if the patient is asymptomatic, especially in the absence of autonomous nodule. When thyroid scan in patient taking osteoporosis drug or beta adrenergic blocking agent, if TSH between 0.1 to 0.5, observation alone is appropriate, and you have to measure TSH free T4, T3 every 6 months. So this is a quick algorithm to summarize what we mentioned before. Maybe you can take screen capture to make it easy for you if you need any revision. Treatment options, the same as over diabetes, beta blocker for symptomatic patient, Graves' disease, need thionamide, radioiodine, surgery, thyroiditis usually symptomatic again with follow-up of thyroid function. A beta blocker is the best option here. Thionamide, I think we mentioned before, what is the side effect? Leukopenia, leukocytosis or renal failure. I need your input, please. Quick revision for you. Many answers going with correct answer A, but still it looks not clear. Leukopenia is one of the side effects that can be seen here. In summary, most patients with subclinical hyperthyroidism have no clinical manifestation, with those with symptoms present like tachycardia, tremor, dyspnea on exertion, weight loss, are mild and non-specific diagnosis of subclinical hyperthyroidism based upon biochemical testing alone. Causes are the same of overt hyperthyroidism, and treatment depend on individualization, as we mentioned before. Quick reminder, EndoDMOS is our Twitter account if you are interested to have more update and revision in clinical field of endocrinology and diabetes. I think it's the time now to go for a break again. We'll have a break till 7:45. So maybe I will leave you now and we'll meet inshallah at 7:45 again to continue our journey.